This is Dr. Mobeen Syed from drbean.com. Welcome to one more show. So today with us, we have a rock star, and we've been having a lots of rock stars. So once again, Dr. Keith Berkowitz is back with us. Keith, welcome.
Thank you so much for having me.
So for the newer viewers, tell us a little bit about yourself before we start asking you questions of all sort and get all your prescription ideas out in the open.
So I've had a pretty interesting medical journey. So I actually started my training actually as a hospitalist, as an inpatient physician. And from there, I went into working for, people may remember the famous Dr. Robert Atkins, who was an integrated physician. And post that, I actually opened my own practice in Midtown Manhattan. My focus is a lot on metabolic stuff. One of my major interests is actually blood sugar and in specific reactive hypoglycemia. And fast forward to COVID, together with other physicians, we started the FLCCC, and that's how I got to meet the great Dr. Mobeen and really learn about now treating COVID, looking at long COVID, looking at vaccine injury, really has become a focus. And I have to say today, I did my training in HIV. I did my training in cancer at Sloan Kettering. Today definitely is the most challenging environment medically than I've ever experienced. I think we're dealing with a disease process that has so many different mechanisms of action that makes it so complicated and so difficult to understand because of that.
I totally agree with you that the complexity of the disease process nowadays and the management process, and on top of this, I think you would agree that with all those waves of the variants and viruses, the shape of the disease process continues to change.
Yeah, and it's really interesting. I mean, we definitely saw it from Wuhan to Omicron, almost like a different virus. And now what's interesting, we were just talking off air, I'm now seeing cases, which is not clearly COVID, because I'm not sure if the current testing modules we use or testing kits we use are picking up all these cases of COVID. I'm definitely seeing in some people with virus illnesses that are becoming more severe.
And tell me this. So this is actually very interesting that you said that the viruses or the newer patients are more severe compared to maybe a few months ago or weeks ago. What is the most common symptom set that you are seeing?
I mean, it's definitely moved to head-based with sinus congestion. We're seeing high fever again, which I hadn't seen in a while. I had a patient this weekend up to 102, 103, which I hadn't seen for, multiple variants before that. We're seeing also gastrointestinal stuff, constitutional symptoms like fatigue, malaise, poor appetite. It's definitely very much flu-like with an upper congestion type pattern. I'm not seeing the lower issues we saw early on, which are lung-based really. And that's probably maybe because we're doing early treatment as well. But definitely people are requiring much longer treatment now than I would say three or 4 months ago.
This is very interesting. So a couple of things. One, I'm going to brag that I used to say that eventually the COVID is going to start creating variants that are going to start living in the lungs, in the throat, and leave the rest of the body alone. And that would be a normal human coronavirus. So here we are seeing more and more moving upwards. The second thing is that I did this study review a few days ago about the EBV reactivation. And in that study, they said that if there is a co-infection or after SARS-CoV-2, there is a reactivation of the EBV, then those patients have higher levels of CRPs and they have greater liver function tests, higher numbers, plus their fever is higher than if it was just SARS-CoV-2. Do you think that you may be having EBV reactivation?
I do agree, and I'll tell you why. What I'm seeing also low, like you were saying, low iron levels. I'm seeing high ferritin, high CRP, which is kind of going back to what I saw earlier. I'm seeing that, and definitely I'm seeing, patients with lingering fatigue that can last weeks after the acute illness, which really during Omicron we didn't really see that much. And again, my favorite thing to talk about, I'm seeing a lot of histamine type issues as well.
Very interesting. So let me ask you something on this histamine and you have been my doctor as well. So I'm going to open up something in front of the people
Is
here.
that a disclaimer, I guess? You have to have a disclaimer.
Disclaimer. Yes, absolutely. So I reached out to you and I said, my cough, I just continue to have cough. And you said, are you really a doctor? You don't understand the post-nasal spray. And then you prescribed glutathione, and you asked that, hey, if you have the antihistamine nasal spray, you can take that as well. So tell me this, the chronic cough of this nowadays, maybe after COVID, what is the best solution you have seen so far?
So it's interesting, and it's a change from before. I would say earlier on we used steroids, right, which was probably the mainstay of treatment, and maybe plus or minus ivermectin. Now I use a lot of antihistamines. I'll also use intranasal glutathione, and the reason for that is actually I do think some of that postnasal issues and congestion is inflammatory, and I think the glutathione has a really good anti-inflammatory effect on that area. And what's different is the cough is not that deep hacking cough we associate with lung issues. It's more that superficial cough that we see most commonly with postnasal drip. And I think that for sure is the most lingering symptom for people. And we discussed this off air. I'm seeing people with 2, 4, 6 weeks after the acute illness still having those symptoms. And what's complicating now, we're in allergy season on top of that, right? So this year is really interesting. With the warmer weather, at least in the Northeast, we started seeing allergies begin in March. So I wonder if people with those allergy type patterns already had elevated histamine levels and made them much more susceptible to getting a much more severe viral illness afterwards.
I think you're very correct, because a couple of things that are interesting for me with the vaccine and the COVID, and before my life, before these things, I never had allergies before. Actually, in my family of four, the remaining three people have allergies. And I used to look at them and say, man, you guys have allergies. Look, I got nothing. And now, since COVID, I had vaccine in 2020, March
One
or April.
of
Ye-
21, right?
21, correct. Right. March, April or May, when it came out, right? Then the COVID occurred the year after, and then it occurred 2, 3 times. Since then, my usual problem becomes cough that just continues for some time. So I think that I have gotten now allergies, and more common, I can become allergic to dust and dander and my own cats that I was never allergic to or whatever. So tell me this, do you see that people who did not have allergies starting to develop allergies, or the people who had allergies having higher intensity, more intensity and frequency of allergies? What is the change you're seeing?
For sure. By the way, that was my interview yesterday with the Epoch Times about that. So what was interesting is I think there's a mast cell issue that's going on where mast cells are so much more prevalent. And I think what's interesting, and I've heard other people say that, the more exposures people are getting to, it's possibly the spike protein, whether it's COVID vaccine, I think the higher histamine levels they're having. You know, traditionally when we looked at mast cells, we would always try and measure tryptase levels to see if it's an issue. Typically, that's very hard to diagnose and very hard to. But what I've done in the practice, and I know they're not most accurate, I started measuring histamine levels, and I'm finding they're chronically elevated in a lot of people, even asymptomatic individuals. I saw someone last week had COVID back in August, still with postnasal drip, allergies, never had them before, and now we're about 8 months later. And so I said, let's show you histamines. His histamine levels were 30 times normal. So
Very interesting.
so he had, I think there's the lingering effect. You know, you talked about the Epstein-Barr virus. I think it's also histamines. I think why people are getting sick is their baseline histamine response is there at a higher level. I think they have this hyperimmune response, which is not turning off, right? Typically, mast cells and histamines should turn off over time as you recover from the illness. What I think what's happening is that mechanism, for some reason, I'm not sure why, is stayed on in an on switch or is in a continual phase.
Absolutely. I mean, look, I didn't have allergies. It is known I did not have allergies. And here I am. I'm sitting with allergies since these events. So thank you very much for this. And a quick note for the cool beans here. Cool beans, I changed my desk setup, moved my mic up here, and then cleaned up my desk a little. And my monitor where the chat and the other things were used to be here. I moved that over here. And one unfortunate outcome is that the chat has gone all the way in that corner. So if you see me moving like this and looking, I'm really not trying to look at Keith. It is really, I'm trying to read your chats. So please, I'll have to figure out how to rearrange this, but you'll have to forgive me today for looking this way to look at your chat. For example, I see there is a fun fact by, I hope it is a fun fact. A person says Omicron, Delta, Deception, and Ross Island are close to each other off of Antarctica. So that is a fun fact, but I had to go all the way over there to go and find it. So please give me this leeway today. So, Keith, I want to ask you the second thing here. Number one, has your COVID management changed in uh, considering these newer the histamines and the EBVs and the variants? How do you manage today?
So what's really interesting that we talked about this off air is ivermectin, which has been a mainstay for us for a long time. I, for the first time, have seen failures, which really didn't happen prior to probably the last month or so. And so we talked about, I have actually introduced a new drug, nitazoxanide, which goes by the brand name Alina. And what it does, what I think where it may be more effective is it's a very good medication against Epstein-Barr virus, where it has really good properties against that, where, and at the same time also can activate COVID. So I think maybe what we're seeing and what you're saying is we're seeing that joint infection. So the joint infection is making people so much sicker than they had previous been. Or maybe happening is Epstein-Barr is staying activated for a long period of time, and the immune system is just not able to fight off a second virus.
Which makes sense. So you're using nitazoxanide
Mm-hmm.
as part of the COVID management because there may be EBV or other viruses, latent viruses that are. So what is the? Tell me the protocol. So imagine if I got COVID today, I came over to you and I'm coughing and fever and all that, and you're going to start me on something. So this is the time people should get their pens out. So we have the secrets out from Keith and put them out in the open. So what do you do? When do you offer nitazoxanide?
Still ivermectin would be my mainstay. I mean, still as first line. I mean, I do. I'm now using antibiotics as well. I mean, and that's my style more because of the anti-inflammatory effects with the nasal congestion as well. So I'll use Zithromax. Sometimes I'll use Augmentin. I'll use a nasal antihistamine spray. Oftentimes, I use the very similar vitamin protocol we've used in the past: vitamin C, vitamin D, zinc, quercetin. I use quercetin with bromelain, actually. I'll put people on a probiotic at the time. Did I miss any quercetin?
Mm-hmm.
I think, yeah. With vitamin D and vitamin C, I've actually been using higher doses more recently, where I'll give a loading dose often of vitamin D now. And I find that very effective. For me, in the last year, as when I felt sick, I gave myself a loading dose of vitamin D, and I really felt better within 24 hours. And vitamin D and vitamin C together.
Got it. Thank you very much. So nitazoxanide has become a part of this as well. Ivermectin is a part as well. Tell me, what is your observation with nitazoxanide? Of course, you started using it and you are using it. How did you start using it? And why do you keep using it? What is the observation that makes you feel that, hey man, I want to use this drug?
I think for two reasons. So I actually used it years ago. So I'm familiar with it in the past. I used to use it for people with blastocystis ammonis, which is a protozoan. It works for Giardia. You know, that's its past. And what's interesting about it, and because it works on the gut microbiome the same way ivermectin does, I think it has such a great benefit because of that. Who introduced me to this again is our friend Paul Merrick, who put it into his protocol for RSV and influenza treatment. And what was interesting to me, I started seeing a lot of cases with long COVID and vaccine injury with acute Epstein-Barr virus or reactivated Epstein-Barr virus, where some of them benefited from ivermectin early on, and I started seeing that benefit wear off. So later on, as time goes on, I started seeing less and less of a benefit. So I was looking for another antimicrobial to really take its place.
Got it. Thank you very much. And then I want to ask you about EBV. How do you know that it is EBV reactivation? Do you do labs? Do you suspect clinically? What is your approach? Here comes a patient. Why would you think there is EBV, and what do you do to verify that?
Okay, so there's two different groups, I say. There's a group where, and I do lab work. So there's a group where you know it's clearly acute infection. They'll have positive immunoglobulin M levels, right? So we know that's acute infection. What's interesting about this, in my 25 years as physician, I rarely saw an older person with acute EBV. It was very unlikely. It was mostly younger people, teenagers. Now I'm seeing people with acute immunoglobulin M levels, but also positive immunoglobulin G levels. So I know they've been exposed before and now have been re-exposed, but re-exposed in an acute way. Then there's a second group, and the second group is much, much harder to diagnose because we know in reactivated Epstein-Barr virus, only less than 4% have positive immunoglobulin M levels. So a large number will have positive immunoglobulin G, which is the longer term immunoglobulin, but so does everyone else. I would say 90, although I had one 50-year-old who never had Epstein-Barr virus, my first case.
So then, do you test for the T cells as well?
Yes. Then what I'll do to differentiate if there's a T cell activation, either in two ways, a lower immune response where CD4 and CD8 are low, or an elevated CD25 response. And that is often a clue. So I figure if the T cell response is activated, then it's probably reactivation or something else where the immune system is being challenged.
Very interesting. Thank you very much for this. And for the physicians or the providers who are listening, please take notes. Dr. Berkowitz's work. I think that it is all because of me that he actually just lays it out there, but it's actually him. So take notes. These are important notes. So there is a good question, and I thought that we'll discuss this in detail as well. So John says, does Dr. Berkowitz use Monolaurin?
And the answer is yes. Actually, you had a guest previously on your show, Dr. Stephen Phillips, who actually taught me how to use Monolaurin. He had experience using Monolaurin in his Lyme patients, especially for chronic maintenance. And yes, I've had started using it with long COVID. I don't use it as much with acute COVID, but more long COVID. Or if I'm transitioning someone off of ivermectin, I may switch them over to Monolaurin. I think it's a very well tolerated. Monolaurin comes from coconut oil, one of our favorite things. You know, it's a lipid-based molecule that has really tremendous broad range antimicrobial effects, viruses, fungi, bacteria. It's an amazing molecule.
So we're going to talk more about long COVID and Monolaurin a little later as well. I still want to talk more about the acute COVID. So the nitazoxanide, what is the mechanism of action that you know of which may be playing a role in the management of EBV plus SARS-CoV-2?
So this is what's interesting about it. I think what's very different about it, its effect on preventing the virus from using ATP. So ATP is our energy source, right? In our bodies, it's the byproduct of the Krebs cycle or mitochondria. It's what makes our engine go. So viruses, and you correct me if I'm wrong, you're the expert. So viruses use our ATP to be able to survive and replicate. So I believe that nitazoxanide, I pronounced it wrong, prevents those cells from using the ATP. In addition, it has a very similar effect that ivermectin does, that it also has an anti-inflammatory effect. And I think that's why it's so special, that it also has broad-based anti-inflammatory and can block a lot of those pro-inflammatory cytokines the same way that ivermectin does.
Actually, this is so interesting. You and I were looking at this as well, that Within our cells, nitazoxanide works on the electron transport chain in the mitochondria and kind of decouples or uncouples the phosphorylation, meaning the electron transport chain from the ATP synthase enzyme. It just dissociates them. And so now, even when the raw material is present, the cell doesn't make a lot of ATP. And if the virus is sitting in there, the virus is not going to get energy to build itself. And all of a sudden, the virus is stopped. And then, as you said, on top of this, it is anti-inflammatory as well. So, could you say that nitazoxanide in acute COVID is a game changer, or it is just, hey, this is one more thing that may be used?
I think it's one more. I mean, where it's a game changer, I think, is in the Epstein-Barr virus. And if you think about, like, we've heard of chronic fatigue syndrome for years, and a lot of people feel that chronic fatigue syndrome is underlying reactivated Epstein-Barr virus. And remember, if you think of where people's symptoms are most problematic, it's the fatigue, the malaise, the exercise intolerance. So if you're able to change mitochondrial function by removing the virus almost impact on that, that's a game changer for people more than anything else. So maybe a game changer, not necessarily for the effect on COVID alone, but the effect on this other reactivated virus that seems to be tagging along these days.
So I want to tell Cool Bean something funny. I think they're going to laugh about it. So Keith is in New York. I am in California. I am wearing this high neck sweater, and Keith is sitting in a t-shirt. He's in a snowy area. I'm in one of the very warm states. So I think this is the.
Well, you didn't say the rest. You didn't say it was 71 degrees in New York, and I think you're in the 60s.
This is also the living comfortably softed in California. Okay, so I have a couple of questions for you as well. ZZ Berman says, what test do we order for T cells regarding EBV reactivation?
So I tend to order a full panel. It's called T cell subset panel. So it looks at CD4, CD8. It'll look at CD3. It'll look at CD25. I think that's the best test to use.
Got it.
And what's important, can I make one more point about that? What's important about that, and this again, and this is, I always teach people, you have to be careful about if it's not in the, if it's off the normal range, or it's in the normal range, it still may not be normal. Let me give you an example. So someone can have a very suppressed CD4, CD3, or CD8. That is still problematic if they're acutely sick. So even if it's low normal, it should be the other way around, right? The body should be fighting off an infection, and the T cells are not responding properly. So it's important to look at that as well. Not only judge it if it's out of range, but if it's low normal, that's problematic, or if it's high, it's problematic as well.
Got it. Thank you very much. There is one more question. Meepalard says, are doctors willing to run tests for histamine levels?
Well, that's your job as an informed patient to make sure they do. I mean, what's so important in medicine is you have to remember the patient's the consumer. The consumer, at the end of the day, really controls the process. And I think my favorite patient is the informed patient that knows what knows more about their symptoms, knows what test, and I think is not afraid to ask. And I think that's your provider. Have that relationship and ask.
Got it. And can you hear this scratching sound? So this is my poor cats after my cough. They're not allowed to come in because I become allergic. So they just stand outside and keep scratching it. It just makes me so sad. Okay, so there is a question here, which actually it's, I think, Talia, I can make sense of this question. Are you eating pork injected with Merck's mRNA livestock vaccine?
Can I answer that for both of us? The good news is neither Mobeen or I eat pork.
So, good. All right, excellent.
How's that as an answer?
That's a good answer. Thank you, Talia, for the question. All right, so one more question from Truth Seekers. And just quickly, Alive and Heal says, beautiful Montreal. And then, thank you, Alive and Heal. Truth Seeker says, how are people who are unvaccinated and have not had COVID yet doing what they get when they get COVID now? That's a very interesting one. No COVID before, no vaccine, now got COVID. How do they fare in this whole thing?
So my problem is my N is 1. right now recently. So I only have one case. It was actually pretty severe, this case, which required not only following with nitazoxanide, but also steroids. Again, the problem is the N of one, because it's becoming more and more of a rare circumstance that people didn't have either. And it makes sense, right? People, as they're exposed, their immunity gets used to it. And I think, especially now, if this is a double exposure with two different viruses possibly, or this, now I heard adenovirus is around. Have you heard the same thing? People complain of norovirus. I'm seeing a lot of 24-hour stomach flu as well. So the question is, if there's multiple viruses circulating, I think people are going to get more severe reactions if their bodies hasn't been exposed before.
Got it. So tell me this, have I asked the right questions for EBV? Because I believe EBV reactivation at this time with SARS-CoV-2 is very important for doctors and providers to know, and then to understand how to manage it. Is there anything I left that I should ask, which you do for
I
your
think
management of?
we should talk about my other favorite medication, which is important, but also the effect of toll receptors. Why we think, and we discussed this off air, why we think people are so susceptible. And if you want, I can start explaining. So EBV is very related to something called toll receptor 8. Toll receptors are proteins that really are involved in our innate immune system. They're one of our first line of defenses within our immune system. And what's interesting is we're now seeing more and more information out there. I read recently about mRNA vaccines seem to trigger toll receptor 4, 7, and 8. So what's interesting is if the vaccine or COVID is triggering those toll receptors, in essence, it's lowering our immune response in the early phase, right? Whenever you get an acute vaccine, early on, you're going to have an immune dip. And I think I wonder if that immune dip in the first 2 or 3 weeks is allowing Epstein-Barr virus, which is normally dormant, to really wreak havoc and really, attack the body.
Got it. Thank you. Thank you very much for this. I have an interesting question, and I have seen many patients with this. Danger Zone says, what causes incredibly sore thighs and tendon pain? Massage and quadricep stretches help.
Okay, so, and then I want to talk about my other favorite medication. We didn't talk about low-dose naltrexone.
Absolutely. I'll go right to the long COVID and then we discuss
so
that.
This is really interesting. So there's a couple mechanisms behind it, I believe. So one, I think actually I'm seeing a lot of glucose insulin discordance, I should use the word, where I'm seeing a lot of patients post-COVID, post-vaccine, and long COVID, where they're having low glucose levels but elevated insulin levels. And one of the consequences of elevated insulin levels is that they deplete intracellular magnesium. And intracellular magnesium definitely has an effect on muscle function. The other thing that we're also seeing as well is the impact on iron. So in an acute infection, oftentimes iron levels will drop, and low iron also affects glucose transport, oxygen transport to the muscles. And the third one is mitochondrial function. If people are having issues with mitochondrial function, again, there's where Epstein-Barr virus can play a role, can also cause the sore thighs and tendon pain as well.
So you are so accurate here, because not connecting the dots on the hyperinsulinemia and then magnesium depletion, I have been asking people to take magnesium. And they say, well, I sleep better now and I have better muscles, the sores are gone, the pains are less. And it is just so interesting to hear that. And here you are talking about it. So Danger Zone, I hope that you feel better. And here is not a medical advice, but what could be the possibilities.
So what's interesting through this, I want to add one more comment, I'm sorry, is I'm using a lot of continuous glucose monitoring now. And you know where I'm seeing the greatest benefit is people with insomnia. So one of my hypotheses behind insomnia is the fact that the people have low glucose levels at night. So we're able to track that backwards and see if that's happening.
Very interesting. And so this one is an interesting question as well. I believe it is in the context of the muscle pains. Could it be arterial stiffness?
Well, if you have low magnesium, that has an effect. I mean, we also have endothelial dysfunction, right, where the blood vessels don't contract well, where vitamin C plays a role, and things like coenzyme Q10. There's a lot of research looking at CoQ10 as well, but absolutely.
Got it. So Alive in Heal says, we see a spike in psoriasis in the last year. Could it be similar?
Okay, so I'm going to switch a little bit for a topic. So I think this is
Let's
a gut
do it.
microbiome issue. So one of the things and this is Sabine Azan and some of my colleague Robin Rose have been really talking about a lot, is they're seeing is a depletion in some of the beneficial bacteria. One of the main ones is bifidobacterium that seems to be really lowered. And also, I'm also seeing is an increased overgrowth issue with things like fungi. We're seeing yeast, a candida within the bowels, and both are really linked to psoriasis. The other thought is psoriasis also autoimmune, right? So if we're seeing an autoimmunity process through this hyperimmune, like for example, high histamines, that will also play a role as well. Complex. That's the tough part here. And that's what's really the challenge, and we talked about this before, is every issue you say, there could be 3 or 4 different mechanisms that could be causing it. Or
Absolutely.
more.
Cool. Cool. So thank you. The takeaway so far, EBV reactivation is important to keep an eye on. There is a new variant of the virus as well. Plus, ivermectin may be less effective at this moment, and nitazoxanide may be another drug to be trying. So with this, I'm going to now switch to long COVID because I want to talk about your second or another equally loved drug, and that is Monolaurin, I believe, isn't it?
Monolaurin
Okay,
and low-dose
so let's
naltrexone.
start with this. Imagine somebody has long COVID. What is your approach to therapy?
So what's interesting about long COVID, I think early on, and we used to use a lot of ivermectin and steroids as our first line. That was really, and I think that's really morphed. A couple things have changed. The drug which I've actually been using for years, I used a lot in my autoimmune practice patients, is low dose naltrexone. That's really become a key factor, and I think there's a main reason for that. I think, or LDN, thank you. We're learning more and more that I think seeing the high histamines, seeing the Epstein-Barr virus reactivation, that it's a hyperimmune response. And I think ivermectin, steroids do help, but and they are immunomodulators. They do help with the immune system. But I think low-dose naltrexone takes it to a whole different level, where it really is able to rebalance what we call Th1 and Th2, the two kind of fighters in the immune system, the attack dog versus the one that's trying to relax the immune system, which is Th2. And I think that's why it's showing more and more to be effective. That I think we're seeing in long COVID, not only Epstein-Barr virus reactivation, I'm seeing a lot of acute thyroiditis with normal thyroid function, where people have thyroid antibodies and changes on thyroid ultrasound, but with normal thyroid function, and a positive ANA, anti-nuclear antibody, which you often see in rheumatological disease. So I would say probably Epstein-Barr virus may be number one, but not so far behind is definitely the autoimmune aspect. And actually, Epstein-Barr virus, we now know, is a huge driver of autoimmune disease by itself. So I think,
So I actually, sorry, please.
sorry about that. So I think where ivermectin and steroids were number 1 and 2, I think now low-dose naltrexone has become number 1, and ivermectin and steroids have moved down one place.
I completely agree with you. For the long COVID, I'm seeing that low-dose naltrexone is the backbone of the remaining therapies. You can hang so many other things on this therapy, but the LDN has to be there. So let me ask you a couple of questions on the long COVID. So one, pathogenesis of long COVID, spike protein related issues. The other is the EBV reactivation. And the third one, I believe, that many doctors are missing, and you hit on this by saying autoimmune disorders. I believe that anti-idiotypical antibodies and an autoimmune uh, action going on in the body, these three are main pathogenesis. Do you feel that these three are correct, or there is something else you're seeing as well?
I think there's 2 others that we'll look at. I think and they may be offshoots of this. I think there's a gut microbiome issue. So the other thing I use a lot of is colostrum or bovine immunoglobulin to really work. And by the way, for histamines, that has a good role as well too, because it really works on the inflammation within the GI tract. And the GI tract is so easily damaged because it's unlike other parts of the body. It's a mucosal layer and it's only one cell layer. So it's very easily damaged. And the other one, which is, I think is the hardest one to really diagnose, is the hypercoagulable state that some people field where elevated fibrin issues with that. And to me, I struggle with that one the most because we don't have good markers to really determine whether that's there or not at this point yet.
Agreed. Agreed. So 5. Thank you very much. So tell me this then. How does monolaurin work? How do you use it? And what kind of results are you seeing?
So monolaurin is really interesting. So again, we talked about coconut oil. And again, what's so important for any of the therapies we use is that they're lipid-based, right? And maybe you can explain that better than I can, that lipid-based molecules are much more effective at penetrating these viruses than any other source, right? Ivermectin's that way, nitazoxanide is that way, and also monolaurin is that way.
Absolutely. So monolaurin is almost like surfactant and emulsifier. And what it does is, especially for the enveloped viruses, which is, for example, SARS-CoV-2 is an enveloped virus. So it kind of coats their surfaces, just like the surfactant can coat our surfaces inside the lungs as well. And that when it coats it, it can, number one, disrupt it from binding. And number two, sometimes it just becomes such a thick layer that it can even puncture the viral envelope and destroy the virus. Now, it doesn't do the same puncturing of our cells, let's say epithelial cells. And the reason for that in the lungs, the reason for that is that we have active enzymes and energy, which is making and restoring the surfactant and the consistency of the cell surfaces and so on. Virus doesn't have any such enzymes and energy going on in its side. So if you attack the virus, it cannot really defend itself. So monolaurin-like products are really good. So tell me this then. What is the symptom set of the long COVID that tells you that I'm going to start using monolaurin? And what do you expect in terms of progress?
So a couple of things we look at. One thing is if it's persistent viral, right? Post-viral, which is really interesting. I mean, and that's whether, I mean, this is still kind of controversial, is it COVID remnants? I've been corrected a couple of times where I've said COVID, but people think it's more remnants of the virus rather than COVID itself. That group seems to do really well because a lot of that persistence may be within the gastrointestinal tract. And I think monolaurin is especially effective in that area, from the way it works, because, it works on the surface there, that group. And I think these are people with, laboratory-wise, they'll have low iron levels, high ferritin, sometimes high CRP, with a really white count that's decreased, which can sometimes go along with the virus. Those tend to be, I call my post-viral patients. They seem to be most affected. The other thing is, again, because it's such broad-based effective on other microbes, is the body actually susceptible to other things? So almost as a kind of preventive as well, does it have, a value there where you're preventing the body when it's depleted or when in the long COVID state from getting other viruses or getting sick? We talked about this in a couple months ago. Both of us saw a lot of our patients who were doing so well in December, January, just have this spike of illness with no diagnosis, no COVID. By the way, I'm seeing a lot of positive COVID after the fact, and they never were positive at the time.
And it was such a surprise that even those who were vaccine injured had become aggravated. People who had tinnitus, their tinnituses had increased. This was just a weird time in January, February, that something happened. Everyone was flared up.
And again, so the question is there a role besides the acute and long COVID in prevention? And I would probably say yes, right? We're using now vitamin C, vitamin D, regularly as prevention, but maybe monolaurin has a value there as well.
Got it. So Dr. Stephen Phillips, of course, is a big fan of monolaurin. So tell us, how do you prescribe it? So I am a patient, I come to you, you suspect that I have long COVID, you want to give me monolaurin. What should I do? What is going to happen?
So typically what I'll do is I don't start besides 1 or 2 drugs, I will kind of stagger them, right? So I'll start something like typically low-dose naltrexone will be really upfront. I use some gut support stuff. I'll sometimes, depending on if they have POTS or not, use some mitochondrial support as well. And then I think and possibly ivermectin or nitazoxanide, then what I'll do is probably 3-4 weeks later in some of these patients, I'll add Monolaurin later and put it as more of a second line. And the reason I do that, I think it's the way I've seen it work is it takes a lot longer for the effect to show as opposed to ivermectin and nitazoxanide. And that could be just my experience because I'm using lower doses. The patients I've shared with Stephen Phillips, a lot of times they'll over time build up to 3,000 milligrams a day. I'll probably start at about 500 and slowly increase over time.
Got it. John says, does Dr. Berkowitz use loratadine or for monolaurin?
I mean, that's a great option. So that's definitely a good option, yes.
Excellent. Thank you very much. This is a good question. Broken Forever says, no hydroxychloroquine?
I actually have never, it's never been part of my protocol, interesting enough. And I think my bias comes about because unlike ivermectin and probably nitazoxanide, hydrochloroquine probably has a negative impact on the gut microbiome, as opposed to we've seen ivermectin, vitamin C, and probably monolaurin does too, upregulate bifidobacterium so it has a gut microbiome improvement, whereas in hydroxychloroquine does not, although we've seen great effectiveness, it doesn't have that positive gut microbiome, and I'm big on that in my practice.
Got it. Thank you very much. Meeple Art says, have you found much of a die-off reaction? I think Hirsch reaction.
Yes, and I think here's what's interesting about even low-dose naltrexone. The patients you got to be most careful with are people with Lyme, chronic Lyme. They have a tremendous die-off reaction. People with a lot of inflammation, especially gut inflammation, will have a tremendous die-off reaction. You have to go very slowly. But Lyme, for sure. I have several Lyme patients that I actually at 0.125 of LDN. I mean, and my normal starting dose is much higher, and that's all they can tolerate.
Got it. Thank you very much. So we talked about COVID, we talked about EBV reactivation, we talked about long COVID as well. I have a very interesting question that one of our cool beans used to ask almost every time. Have you seen long COVID patients fully recover?
So what's interesting, first, what's our definition of fully recover? And I think that's a challenge.
I see you, Ruby. So sorry, Keith.
It's okay. So I definitely see people, I would say the one symptom that's a challenge for me is tinnitus. Very hard to, those are the group that I don't always see improvement in, unfortunately. The people with very severe histamine reactions with a lot of autoimmunity, very hard to treat. But I would say the average long COVID person does get a lot better. And I think I would say probably at least 70, 80% better. I think I'm a little wary of saying 100% because I'm not sure what that means. And again, the one thing I worry about is is the spike protein gone? And I think we're having a lot of trouble understanding that. I mean, do you feel that same way as well?
Absolutely. So I feel that there are so many things that get triggered, autoimmune diseases or the anti-idiotypical antibodies or mast cell activation or macrophage disruptions, immune system imbalances, that in some patients it doesn't seem like they ever go back towards normal. They just get stuck. Just like if I have now allergies, I don't think these allergies are just going to settle down anytime soon. And now I'm stuck with it. So it looks like the symptom set does become recovered 80-90%, but there is still some inkling that I have this. And there is another thing that I'm observing in patients. They know what will I do when I'll get a relapse. Do you see that too?
Absolutely. And so there's another caveat I forgot to mention. Timing to seeing them. People I see much earlier have a better outcome for sure. I think the longer the process is, and oftentimes I may not see people for a year or later after the symptoms start. Those are much harder to treat and take much longer. But definitely, I mean, my biggest concern in some of the more, the sicker people is that they're very easily triggered again. So their symptoms will get better, but an infection, acute stress, things like that will re-trigger many of the symptoms, and that's the hard part. I think what I find is people get to at least a functionality level and a good functionality level, but is it full repair? I'm not sure about that yet.
Got it. I would actually tell you a story about a patient, but before that, existence.com says, what about nicotine patches for long COVID?
I mean, I've never used it. I mean, have you? That's not part of my normal armamentarium. Doesn't mean it doesn't work.
Absolutely. So GK says, Dr. B, do you do telehealth? So is that Dr. Berkowitz or Dr. Bean? So Dr. Bean, no, not in the US. And Dr. Berkowitz, how about you?
Yes, and actually, yeah, and I do in New York, New Jersey, and Florida.
So how did they reach out to you? Is there a website or a phone number? How do we find you?
So website is centerforbalancedhealth.com, and email is info@centerforbalancedhealth.com, or phone number 212-459-1700.
Thank you very much. So now I want to tell you a story which, when you said that the earlier somebody is managed, the better the outcomes. There is a patient who, in Pakistan, I was visiting various colleges. I wanted to make sure that there is an awareness about long COVID and the vaccine injury. And because this gap between the acute disease over and the new disease starting, and that 1 month, 2 months, a few weeks, that gap is enough to disconnect the long COVID from the COVID, and people just do not know what this is. And so I wanted to create this awareness that one has to be very, very careful if there is this symptom set that just emerges out of nowhere. So I was sitting at the airport, and there was another American who was coming back to US, and we were talking, and he said that, what were you doing here? And I said I was going to various colleges, and I was creating this awareness. In the US, we are FLCCC, there are so many people who are working on it. In other countries, maybe not as many. And he said, so what do you mean by vaccine injury? What do you mean by long COVID? And as I explained it, his eyes just kept widening. And then finally he said, you know what? My wife had her booster a few months ago, and now she is declared bipolar, and her doctor has started her on psychiatric medicines, but she was never like that in her whole life. And she said that she wants to die. Meaning there were lots of neurological and psychological symptoms. I said, maybe think about long COVID or vaccine injury as well, and maybe go to FLCCC, look at the protocol, discuss with your doctor. Now, mind you, that doctor had put her on psychiatric medicines, and he was saying they are doing zero help, nothing is helping.
Can I
Then he
address
came back. Sorry?
I think when we're done, I have an idea why that's happening. I'll explain.
Yeah. So he said nothing is helping. Then he came back. He went to the FLCCC site. He saw the drugs. He went to doctors, and they prescribed her. It's now, whenever I came back, I think it's about a month or so, he has been consistently sending me messages since 2 weeks of her using these drugs that she's fine. So yesterday he sent me a message saying she is active again. She's taking care of the children. She's going to their school. She's working with them for the homework. She says, I don't have suicidal thoughts anymore. And I was thinking, I'm grateful that she is feeling better, but how many patients are out there who will not even have a thought, or their doctors will not even have a thought, that this may be long COVID or vaccine injury, and they'll keep going in that state for a long time and probably be stuck with that, or not become recoverable easily, or have tissue damage. Do you see this?
Yeah, I have one of my own patients, which was recent, which is a really interesting study, developed iritis, which is inflammation of the eye, went to a specialized ophthalmologist, retina specialist, and did this whole autoimmune workup. And her and I sat down, and I said, this is long COVID. And it turns out, and unfortunately the specialist doesn't believe me, she has acute Epstein-Barr virus. the acute Epstein-Barr virus is triggering the eye inflammation. And what's interesting about this specialist is he's like, oh, herpes viruses trigger this. And I'm like, is an Epstein-Barr virus a herpes virus?
It is the herpes virus, yes.
So this is my own patient who I've known for several years, didn't realize her symptoms were long COVID. I would say I have a fair amount of patients that come to me with autoimmune symptoms or other things that had no idea that there was a relationship with long COVID. Do you mind if I address that other patient? I have a thought about that for a second.
Absolutely, please.
So a couple of reasons. One is the thyroiditis we talked about with the thyroid. But a more interesting one that I've been finding more and more is there's some research now looking at gut microbiome, especially we call Bacteroides and Firmicutes. Bacteroides and Firmicutes are really interesting. The balance of them is so critical for the production of GABA. So I'm seeing a large uptick in anxiety. And what's interesting is, and maybe insomnia from that as well too. And remember, if you think of bipolar is often triggered as its first symptom is insomnia. And what's interesting, and also, by the way, blood sugar dysregulation can also affect that too. But what's interesting is those tend to, and there's a group that's more susceptible. We've talked about this before. It's the group that are positive for the MTHFR gene. So the MTHFR gene is a gene that's about, I think it's up to 40% of the population. It's very common in Eastern Europeans, in Mediterranean as well, and some other groups as well. And what the problem with that gene is people are unable to take folic acid and use it into a form what the brain uses, which is called methylfolate, which is one of our precursor for production of serotonin, dopamine, norepinephrine. So what happens is these people, and I would definitely say my most severe long COVID or vaccine injured are people that have two copies of this gene, or we call homozygous, especially a variant called 677. And I find that the reason I think they're so sick, without the ability to produce a lot of these neurotransmitters, their body doesn't handle stress very well, both from a mood standpoint and also from an energy standpoint.
Got it. So thank you very much. I would also discuss this with him to discuss.
Sorry to add that, but
no, thank you very much. It's actually my usual need from you is that when you're here, you lay out the prescription so people and doctors and providers can hear and listen and maybe incorporate some of that and help people.
You know what's so interesting about that point, and my style of practice, I think what's so challenging here is sometimes you have to cast a wide net. And I think because there's so many different mechanisms, sometimes, and I do that through blood work oftentimes, is I'll order more tests than I generally would for a regular patient in people that come with either vaccine injury or long COVID, because I find that slight things may be off and we don't always realize that.
Got it. So this is the set of questions that I have. Is there anything on the closing? Thank you so much. We are like almost an hour of your time, and you are on the East Coast side. So thank you very much. Anything that you would advise to providers, physicians, patients, considering the state of affairs now?
I think you brought a really good point, and I've talked to other physicians. I think the other problem is physicians don't also recognize long COVID or vaccine injury. I think it's very important for individuals to start and learn and educate themselves. And when a symptomatology doesn't make sense, to look at these as options. I think that's so critical, right? Do you find the same thing, that talking to other physicians, they also, so it's very difficult for a patient when they go see a physician, if the physician doesn't, or the other medical provider, I should say, any medical,
I have
those symptoms.
I have no idea how to solve this. There are providers, there are physicians who, in an effort to say that vaccines are awesome, they would not consider anything else, vaccine injury or long COVID, and not educate themselves, not bring themselves a notch up, because it is the need of the time. Look, the whole world went through a pandemic. We are not emerging out of it in a healthy state. We all have some sort of a damage. May that be psychological or financial or health. And we have to have, the doctors have to have open mind. look at the evidence, do the studies, and figure out. I worry a lot for vaccine injury and long COVID patients because of this disconnect from acute to when it starts, and not much physicians are helping.
The one
So,
thing I'm not sure about, and this is what I cannot understand in my colleagues, is patients come to you because they're not feeling good. People do not make up symptoms. and if
correct.
and I think what's where they struggle, and I see with this more than vaccine injured every and one any other group, is they're bothered by the fact that no one believes them. And what's interesting, this is our previous chronic Lyme patients, our previous chronic fatigue syndrome. We can name syndrome after syndrome over years. And I think, if I can say to medical providers, or is you got to listen to the person in front of you. They're going to lead you to the answer. It's not the other way around.
Absolutely. So Denise says we're all maimed, agreed. We are all broken in some way nowadays because we came out of such a huge challenge. And physicians have a responsibility to bring themselves up to speed to figure out how to help. So, sorry, Keith, you were going to say something.
So the other thing which is so interesting is the destruction of personalized medicine, which was such a push before the pandemic that all of a sudden that just got through. And I've always learned as a physician, ethically, our duty is only to the person that's in front of you at the moment, no one else.
So one last question. I was going to wind up here, but I'm seeing a communication going on in the comments.
I
Eye
have time, by the way.
issues.
I got time, so.
Okay, thank you. Eye issues and eyelid issues. Are you seeing vision problems, and are you seeing physical eyeball and the eyelids and conjunctiva issues?
Yes. So both from a histamine issue, someone mentioned iritis, they saw in chronic Lyme. So iritis is an autoimmune issue that affects the eye, the iris of the eye. But more, and that goes back to our histamines, again, remember, when people have a cold or allergies, one of the areas of the body that's affected is the eyes. You can get cobblestoning when you have an acute allergic reaction, which is kind of, I don't know if you see cobblestones on, divisions, and it affects the eyes. But that, I think, is very much related to sinus issues, histamine issues, really important in that aspect.
Margaret says, Dr. Berger has just mentioned my newest neuro symptoms, intolerance of stress, overreacting to the point of near rage and sadness. So, do you see this more often with the patients?
Absolutely. And I think what's interesting, so I talked a little bit about GABA before. GABA is our main inhibitory neurotransmitter that helps us relax, helps us sleep. And I think there's definitely an issue with people with neurotransmitter production. And remember, a lot of the neurotransmitters are made in the digestive tract. GABA is almost, I think, 90+% made in the digestive tract. So again, if there's damage in the gut microbiome, that's going to have an effect on every part of the body. And that's why, and I've been pushing Paul on this, by the way, that I feel so important that part of early treatment for long COVID and for vaccine injury is gut microbiome support. Very critical.
Very interesting. So, Pella Bowles says, can body shakes be a symptom?
I've had my colleagues talk about in vaccine injury, yes. Pierre Corey has talked about that with some of his patients. I have not seen it in any of my patients, but yes.
So, got it. So Scorpy says, those red eyes show up fast and disappear just as fast. It's so strange. What do you think could be the...
So the question is that histamine, right? So histamine reactions, like I don't know if anyone's ever had an acute allergic reaction. I have an allergy with fish. So I'll have an acute reaction, but once that allergen's removed, that will recover. So I wonder if the red eyes is that acute histamine response.
I had the same idea that maybe this is an allergic exposure. So Broken Forever says, Dr. Bean, could you please ask about natto use with any patients?
So I assume they're talking about nattokinase.
Correct.
So
Correct.
nattokinase is a great mechanism, and there's a lot of really emerging research talking about its ability to get rid of the spike protein. In addition, really helping people with some of the hypercoagulable stuff.
Yes.
And that's, I think it's that nattokinase.
How helpful has it been for the hypercoagulable state? Does nattokinase do good enough work?
I think you have to use People are using more than that, often lumbar kinase with that, and sometimes therapeutics. I know there is Dr. Jordan Vaughn, who we both know, who uses aggressive triple therapy, and I think he's using a new testing. One of my patients just saw him. We could talk about this, or maybe you should have him on your show. And he's using triple anticoagulant therapy to treat that. He feels that it's a much higher percentage than we think, and we're not diagnosing it because we don't have the accurate lab test to prove that.
Got it. Thank you very much. Nipa Gandhi, she's actually a dentist from India. She says, Doc, do talk about boron. So do you have any experience with boron?
Not with COVID. With boron, obviously, we use in bones and stuff, but maybe you can talk more about it. So it's not part of my...
I will have to read it up before I start.
You know what the challenge here is? There's probably so many molecules that are effective, and that's NAC I can talk about.
Yeah. So talk about NAC. Tell us more about NAC.
So NAC is really interesting. You know where NAC comes from? I don't know if people know this. So when people come to the hospital with Tylenol poisoning, the first thing they use is NAC-D-cysteine. So NAC is really interesting. Another molecule that is so effective probably in reducing the spike protein. We talked about nattokinase seems to be very effective. NAC seems to be very effective. Vitamin C, ivermectin, resveratrol, autophagy or intermittent fasting works really well. NAC is a couple things. It's a precursor to glutathione, which we talked about, which helps build and we feel that antioxidant depletion may be one of the reasons for long COVID as well. It also works well in acute aspect of the disease. It has very good lung penetration as an anti-inflammatory. And it actually has a side use that a lot of people don't know about. It's actually also used for obsessive compulsive disorder.
Very interesting. So I want to tell you a story for this question, Joshua Wood's question. So Joshua Wood is saying, what are you doing for people with dysautonomia or POTS? And I want to tell you some story before you answer this question. There was a friend of mine who had palpitations, and she was a big CEO and she had sold her company, rich woman, and she had these palpitations. I spoke with you and I said that here is a patient, and you said, and I think I'm going to ask you again to tell us, but I discussed what you had mentioned, and she discussed with her doctor. Her doctor actually did treat her the way you had advised, and guess what? She became okay, and she was suffering for 6 months. So she called me afterwards and she said, even if somebody would have asked me to pay them $1 million for this problem to go away, I would have done it. So this issue of, we both missed out. I see that.
But we got the satisfaction of helping someone else.
This issue of dysautonomia or postural orthostatic syndrome, or when patients say that when I stand up, I get palpitations and my heart beats, what is the solution?
So what's always interesting, and I think we've forgotten this in treating any viral illness, right? So one of the keys is hydration, right? If you come to the hospital and you're sick, what's the first thing you get? Intravenous fluids. What happened during COVID is so many people were managed at home, right? So they didn't have that option. So the reason why you want to do that, you want to get the body to a state, we call it euvolemic, because when the body's dehydrated, it has to work harder. Something called stroke volume increases, right? So stroke volume is either blood pressure or pulse. Your body has to respond with either higher blood pressure, higher pulse to compensate for the fluid depletion. One way you actually can tell, people often get an echocardiogram, they'll see what we call an elevated left ventricular ejection fraction. The heart is pumping harder and faster. And so what happens is I use that with magnesium. That's first line therapy. Once that euvolemic, one of the tricks I use in the office, I actually give people intravenous fluids until they have to urinate.
Until they
have to urinate. So that's the trick to see if they're euvolemic. So once they have to urinate, their body. Number two is the other treatment, which is really effective, is intravenous vitamin C. And I think people don't realize, or they forget, vitamin C is such a great stabilizer of endothelial function. By stabilizing endothelial function, you actually can improve blood flow. and we learned this from Paul Merrick. We've talked before about in the hospital they'll give intravenous vitamin C with steroids to really help stabilize blood pressure. When people are acutely sick with sepsis. So vitamin C is so important for that purpose. But I don't use that first. I use that as I hydrate first, then vitamin C. I mean, other things we can use like CoQ10 works really well. People use arginine. You have to be careful on arginine. You can't use it in Epstein-Barr virus because it can trigger that reactivation. Things like NAC help. Vitamin D is a really great stabilizer as well of blood pressure and endothelial function. But the mainstay is always making sure someone's properly hydrated first. It's such a simple thing, but it's often overlooked.
So that's what she did. She got infusions and then vitamin C, magnesium, and she was fine. It was surprising. So
She
thank
knew
you
it
very
was
much.
the
Sorry?
patient. So, and I have to give credit to this to my mentor actually. So people used to think of Dr. Atkins and diet, right? He's famous for a low carb diet, but he was really a brilliant integrative physician. He had taught me early on about the importance of vitamin C, how it affects health, and where I got introduced to it, and maybe even before Paul, so we'll have to check dates, is in 1999, I went to visit him and I met these three women who had breast cancer and were told they were terminal actually. And each of them was given that diagnosis 20 years prior. So the terminal diagnosis got extended for 20 years and their mainstay of treatment was actually intravenous vitamin C.
Very interesting. So thank you very much for that. I keep saying that this is the last question, but there are
We have
I
time.
can tell you that we can keep sitting here for 10 hours and continue to talk with you, and we will not be done. We would still be thirsty for more.
So why don't we do
I'm
another
gonna,
10 minutes? But I'm okay if you want to do another 10 minutes.
a couple of more questions. One is Nipa says, should magnesium be taken once or twice a week or daily?
I typically, and again, there's another part to that. I typically give it daily, and depending on the sources. What people have to realize, magnesium, depending on the form of magnesium, its impact will be different. There's your laxative forms, which are more citrate and oxide, and the one that actually penetrates the brain better is threonate, magnesium threonate, and then there's glycinate, which I use a lot, or taurate in cardiac conditions. So it really depends what the use is and how often you do that, you give it. And for things like POTS and dysautonomia, probably twice a day is probably the most appropriate.
Excellent. Thank you very much. Last question. Alive in Heal says, my hormone doc wants me to take NAD MB drip. Makes sense.
What's the MB?
I think that may be methylene blue.
Oh, okay. I haven't really used much methylene blue. What about you in your practice?
So methylene blue oral, people have been saying it works. Some say that it works good for them. Some says when they stop, it's the symptoms come back. So it's temporary solution. How about NAD?
So NAD is interesting. I think NAD probably has, and again, NAD for people, that's important. It's a cofactor within the Krebs cycle. So like CoQ10, NAD is another cofactor. I probably find it's probably more helpful as people already are feeling better to really bring their energy up to a better level. I've had people use it in the early stages with not as much positive impact. More later stage to enhance an effect that's already happened. For like your back to baseline, your energy isn't where it should be. There's where the benefit is.
Got it. So truly this time we'll stop. Thank you so much. I think we should invite you again, and there is so much more to discuss as well. I'm very interested in MECFS as well at some point. So thank you very much. Thank you for being generous enough to actually share your prescriptions, your methods, your way of working. I had once in the early time of COVID, a doctor who joined who was actually great doctor, knew a lot. And I kept asking him for some prescriptions and some methods, and he would not tell. And he would just keep saying a drug, O drug. And it was just a disaster in terms of bringing value to providers. So thank you very much for your generosity.
Well, it's so important in this stage, right? We talked about if the providers aren't educated, see. I learned something so important, and this is what I learned from Dr. Atkins. So can I end with one more thing before?
Please.
So I want to talk about a conversation I had with Dr. Curry 2 years ago. So we discussed, or 3 years ago when we first started the FLCCC, he was talking about how we have to change doctors. Doctors will change. That's the change. And I go, no. I've watched Dr. Atkins try that. It didn't work. What he did, he was actually able to, and he became even more popular. He went on Larry King. Larry King was the big person in those days in the early 2000s, and he educated the consumer. So I think one thing which is so great today is the consumer has so much access to information, and the consumer really can become that advocate for themselves and become a better patient. I think the key to being successful as a patient is to become a better patient and a more informed patient. So then you could change the practitioner, and I think that's what's happening more than ever before, which is a good thing.
Absolutely. And there is a cool bean. I'm smiling. There's a cool bean who actually just named the doctor that I am talking about. So imagine this, that there was 2 years ago that interview, and people still remember that we couldn't get the value for the time. So thank you very much, and have a great night.
You try drugs to get truth serum or something? That doesn't work.
Sorry?
Truth serum from them to see.
Yeah, we should have given them the truth here. So thank you very much.
With pleasure.
Have a good
Thank
night.
you.
I'm going to request you once again in a few weeks to come back and discuss some more things.
With
And
pleasure.
Cool Beans, thank you very much for your generous time as well. It is more than an hour. Thank you for being here. Please
And
like,
actually,
subscribe,
I will
and
see you
share.
in 2 weeks, I think.
Yes.
We'll see each other in 2 weeks.
Yeah, so we'll be in the FLCCC conference as well, correct? And then we'll come back and we'll do some more chats as well. So with this, thank you very much. And if any one of you want to support this work that we are doing right now, there are links in the description of this video, and you can do that. With this, thank you very much. I would see you not tomorrow, because tomorrow are the Supporting Beans Zoom sessions. I'll see you on Thursday. Bye for now.
Have a nice evening.
Thank you, Keith.